Good afternoon, everyone, and thank you all for joining us for the 7th Real webinar. My name is Agnes Ronan, and I'm the head of programs at PATA. I'm going to be chairing this session for you this afternoon. And just a little bit of background for those who may not be familiar with our PATA Real, with what PATA Real is all about. Our webinars provide a platform for frontline healthcare providers to come together and share clinical cases relating to treatment regimens and treatment optimization. So the webinars came about as a result of recognizing that the reality of service delivery is very, very different from what we're prepared for when we have nurse training or when you go out into the field, or we can have all the guidelines, policies, and all the training. But I'm sure many of you will agree that all of that only partly prepares you for what we face when it comes to actual implementation. I'm sure many of you will also agree with me that there's so much more learning that comes on the day-to-day job actually doing and dealing with real patients. And the sad thing is a lot of these rich learnings do go undocumented. There are no platforms for sharing with others. And so PATA Real webinars provide that platform where frontline health providers can come together and share real service delivery challenges or learnings that they experience when they are supporting young people and children with treatment and treatment optimization. So what does REAL stand for? Okay, we've got our slide there, just telling you what REAL stands for is about reviewing of cases that health providers see on the front line. So we'll hear of some of these cases in this session by the health providers who saw the actual clients. And as I mentioned, we'll be engaging you as peers and sharing the cases that our health providers who are presenting today have either found challenging or think that there's an opportunity for others to learn from the cases. And at the same time, we have an amazing panel of experts who will then help us to relook at these cases, unpack the cases, and try and understand what was done well or what could be done better. And I'll introduce the panelists to you in a minute. And then lastly, I really hope that we will all learn. So the L in the REAL is about learning lessons. So I hope each of you will learn a lesson or two from the cases being presented today. So just to add that all our cases, as I've mentioned, are prepared by health providers. We support them with preparation for presentation, but we in no way change the essence of the cases that are being presented. So we really do try and keep it real. So as you can see on the slide here, our session, this format of our session is that we have 3 presentations from facilities in Malawi, Mozambique, and South Africa. These will be presented by health providers, as I've already said, and I'll introduce each of them as they come along. And then after each presentation, our expert panel will then step in and comment. So first of all, we'll have a clinical expert who will comment on the clinical aspect of the case. And then we are very excited to share with you that we now have a psychologist on the team. So I will introduce you to her in a minute, and she will step in and she'll comment on the psychosocial component of the case. So really great panel we have, and I will introduce you in a minute. And okay, thank you. There we go. There's our panelists. So Dr. Mo Achery is a pediatrician and a specialist in HIV treatment. Many of you have been on our webinars. I've met Dr. Achery many times before. Dr. Achery is from King Edward VIII Hospital and the University of KwaZulu-Natal here in South Africa. And among a long list of other things, please do read the bios of our speakers. Dr. Achery also serves on the PATA Technical Advisory Panel. So we're very lucky to have Dr. Achery as our technical advisor. Our second panelist is Nandita Sugadi, who's also a PATA board member, as well as serving on the PATA's Technical Advisory Panel as well. And then our third panelist, who I just mentioned, the new addition to the team, is Bahati Kasimonje. Bahati is a psychologist, and she's from Newlands Clinic in Zimbabwe. And like I said, just like the experts, she will engage with our presenters, reflecting on the psychosocial component of our cases and providing recommendations, because quite often, we're very busy dealing with the clinical component in our day-to-day work, but psychosocial, plays a really huge part in whether our clients adhere to their medication, come back to the facility, and their whole well-being outside just taking the medication. So we're very pleased to have Bahati supporting us with this. And then lastly, I'd like to acknowledge Christopher Yamkani, who's in the background, who's been providing us with technical support and preparing our presenters for preparing the cases. So I'd like us to delve straight in, but before I introduce you to the speakers, just remember, if you please do type in the chat box. We'd really like to understand who's attending these webinars. So please type in the chat box who you are and where you're from. That would be great if you could do that. And then if you have any questions, please post your questions in the Q&A, which our speakers will try and answer as we go along. And we'll also have an opportunity, if we have time, to answer some of the questions live, but we'll make an attempt to answer each and every question that is posted. And when you ask your question, please do remember to say who is directed at, so the panelists know to respond to you. And lastly, we have got translations for those who are preferring other languages. If you click on the interpretation box, you'll see the languages we've got available, just to choose the language that you prefer. And just a note to say, we've got a presenter from Mozambique, our third presenter from Mozambique, Constancia, will be presenting in Portuguese. So I'm going to be asking everyone who's normally not choosing translation to click on the English translation, so you can hear the presentation in English as it will be presented in Portuguese. So I'm going to dive straight in and introduce our first speaker. So our first speaker is not actually a health provider, and our first speaker is Anushka Swat from the Division of Clinical Pharmacology at the University of Cape Town here in South Africa. And Anushka will provide us with a little bit of a background in terms of the work that they do and the case that she's presenting. So over to you, Anushka, and welcome. Please enjoy.
Good afternoon, everyone, and thank you, Agnes, for inviting me to present a case at your summit. Just to clarify that this case was received by the National HIV and TB Healthcare Worker Hotline, which provides a clinical query answering service to healthcare workers in South Africa on any TB or HIV-related queries. And on the first slide, there was actually an email address that you can go to find some of the material that I will be referencing later on in the presentation. Next. So this case that we dealt with was relating to a 12-year-old female patient diagnosed HIV positive at 4 years of age in 2014. The mother had died in 2019, and the child was living with her 72-year-old granny who has poor vision, and 4 other kids who unfortunately we do not have an HIV status for. Granny has also not disclosed the HIV status to this child. So the child was started on antiretroviral therapy in 2014 and was also diagnosed with pulmonary TB 3 months ago. All household contacts were screened for TB at the time, and if eligible, patients receive TB preventative therapy. The child is also currently failing antiretroviral therapy, responding quite well to TB treatment, and is currently on continuation phase of rifampicin and INH. So if we look at the treatment history and a little bit of the laboratory evaluation, this child was started in April 2014 on abacavir plus 3-TC and efavirenz, and did quite well even until June 2018, when she had a viral load that was less than 50 copies per ml. And then I think what happened is the mom passed away, and in June 2019, the child presented again with a viral load of 150,000 copies. Adherence counseling was done, and the child was continued on abacavir, 3-TC and efavirenz. Unfortunately, due to the COVID pandemic, the child was never seen during 2020 and then represented in April 2021 and was reinitiated on the back of a 3TC and efavirenz. In September, a viral load was done, which was 32,000. They once again did adherence counseling, and the granny admitted that they were having some problems with adherence. Viral load was repeated in December 2021 and in March 2022, and was 22,000 and 15,000. Obviously, there should have been some intervention here, but we often see this, that patients are kept on failing regimens for long periods of time. And then in August 2022, the child presents again with a 3-week history of coughing, feeling unwell, tired, and the current weight is 30 kilos. A gene expert is sputum positive, RIF sensitive, and the sputum AFBs are negative. So the child is started on TB treatment with rifampicin, INH, pyrazinamide, and ethambutol, and continued on the back of a 3TC and efavirenz. In November, the child comes back to the clinic, has responded quite well to the TB treatment, has gained some weight, now weighs 33 kilos, but the viral load is now 103,000, and currently on the continuation phase of TB treatment on RIF and INH, and still on the back of a 3TC and efavirenz. So eventually, a nurse decides that we need to do some sort of intervention here for this viral load, and she phones the hotline for advice. And at that stage, we basically educate, we tell her to do a serum creatinine, a CD4, and to change the child urgently to second-line antiretrovirals. We recommended TLD, tenofovir, lamivudine, and dolutegravir, plus extra 50 milligrams of dolutegravir 12 hours after the fixed dose combination to counteract the interaction between dolutegravir and rifampicin. And the bloods come back, the creatinine is 44, CD4 112. Next slide, please. So what were our key challenges for this case? Well, firstly, this patient weighs only 33 kilos, and the current South African guidelines for adolescents who fail efavirenz-based regimens only recommend the combination of TLD if the child weighs more than 35 kilos, is more than 10 years, and the creatinine clearance is more than 80 mils per minute. Alternatively, we would have to put this child on AZT, 3TC, and lopinavir, ritonavir, or dolutegravir. Another challenge with this case really is that we need to select the most appropriate second-line regimen, taking into consideration pill burden, drug-drug interactions, and social circumstances. We want to make it as easy as possible for compliance purposes. We need to think about the drug interactions between dolutegravir, lopinavir, ritonavir, and rifampicin. We need to double dosing if required. The other challenge that I think this nurse has is making sure that there's disclosure to this patient. And then with a lot of the cases that we see, and I'm sure you see it in the clinics as well, is we often have limited medical history. We unfortunately didn't have a lot of medical history to go on in this specific patient. I just also want to basically show you the recommendation from the current South African HIV guidelines, which basically state that in adolescents that are failing abacavir, 3TC, and efavirenz, you can consider TLD for their second-line regimen, being a once daily well-tolerated regimen. TLD has significant adherence advantages, while the risk of cross-resistance between abacavir and tenofovir is relatively low. And that's why we picked TLD in this patient, and we decided to give tenofovir to a child that is not yet 35 kilos. And that's what we learned from this case, that sometimes you have to deviate from current guidelines to meet the needs of the patient. What we also learned from this case is, and we see this a lot at our hotline, is that patients are often left on failing regimens for extended periods of time. People do the laboratory tests, but they don't always respond to them in the way that they should. And then I think also knowing the family circumstances is important to provide appropriate adherence counseling for this specific patient. I just want to show you the next slide, which is a very useful pediatric dosing chart that has been compiled by the Child and Adolescent Committee of the South African HIV Clinician Society in collaboration with the Department of Health. And this is the very new updated version, which has been finalized, but it hasn't been officially released yet because we're waiting for our new guidelines in South Africa to become available. We're hoping that these will come in December. And I just want to show you why we sort of went with, if you look at the light blue column in the middle, dolutegravir when on rifampicin, you will see that with this new chart, the weight ranges have changed slightly compared to the previous chart. We always only used to recommend tenofovir from 35 kilos up, but this new chart, which is not yet part of the guidelines, but we help to compile it, so we're aware of what's going on, now recommends in children from 30 to 39 kilos that you can actually use TLD together with an extra dose of 50 milligrams of dolutegravir in children who are on rifampicin at the same time. So this came in very handy for our case, knowing that this new dosing chart was on its way, and therefore we were quite happy to recommend tenofovir in this child who wasn't weighing 35 kilos yet. So we move on to the questions for the expert panel and see what their take is on this. Thank you very much.
Thank you so much, Anuska. So I will hand over this first case to Dr. Archery to speak to us about the clinical components and to speak to Anuska's questions, which are on the screen. And then after Dr. Archery, Bahati, if you could step in and then speak to the psychosocial component. Thank you.
Yeah, thank you very much. I think interesting case. And again, I think it does highlight, firstly, I think, the difficulty is, and this child seems like she was doing quite well until she hits, adolescence. And I think, one of the major issues, and I think that's something that, hopefully we'll have some discussion around, is around this issue of disclosure. And it seems that, that was, it seems like a major component of the difficulty with engaging this child in care and understanding why she's taking treatment. I think, again, as you've highlighted, I think one of the striking things, especially with children, is this reluctance to change or switch treatment. And certainly in a child, failing a efavirenz-based regimen for over 3 years, there should have been interventions and switching much earlier. But we often find, people try to wait and hope that things will change, and it never does. And you don't have the CD4 counts, but I assume because the child has acquired TB because she is immunosuppressed and has some susceptibility to TB. So again, I think highlighting that you don't want to wait, keep individuals biologically unsuppressed and allow their immunity to get worse off and then acquire co-infections. I think to speak to your specific questions, the issue around the use of tenofovir in children is been a shifting target. So just to say, the WHO guideline recommends using tenofovir in the current format, which is the 300 milligram tablet, which is part of the TLD in children over 30 kilograms. The South African guidelines were slightly, more stringent, and we initially had said 35 kilograms, largely because we were concerned about bone and renal toxicity. But certainly from that time point in the interim, there's been multiple more cohort studies that give us some degree of surety that that there's no signal that there's excessive amounts of toxicity in use of tenofovir in children between 30 and 35 kilograms. And so that's why in the new guideline, which will be released on the 1st of December, the South African guidelines will move to allowing TLD to be used from 30 kilograms. So maybe the question then will be, what do you do in a child less than 30 kilograms? One of the concerns is, going down below that, the dose becomes extremely high of tenofovir, and you have to use an alternative NRTI. And in that situation, so if this kid was 25 kilograms, and your alternative NRTI will have to be AZT, 3TC, and dolutegravir and then switching the child on to TLD when they reach an appropriate weight of 30 kilograms. And so that's something that you can quite easily do and keep them going. The other alternative, and it's not always available, and is TAF. So TAF is a tenofovir alafetamide, and that's registered from 25 kilograms. And there is, there's availability of it in some places, but not everywhere. So it's not part of the routine regimens, but is an alternative to Favrans in this younger situation. The only other comment I wanted to make is before again, I think a lot of this really is around this, the need for improved adherence and the disclosure comments, issues that need to be delved with, is in terms of use of tenofovir, apart from, so whereas in children, you have to calculate the creatinine or calculated creatinine clearance. Apart from just looking at the creatinine, you do need to have the height of the child, so it's adjusted per height. And there's quite a few, apps that you can go on to that will, you just put in the creatinine from the lab value and the dose and the units and the height of the child and the age of the child, and it will spew out a calculated creatinine clearance. We often use what's called the bedside Schwartz formula to working out the creatinine. And that again is to give you some idea in terms of whether there's some renal impairment that would be a contraindication for use of tenofovir in this child. So again, I think just to highlight the need to do a calculated creatinine clearance in this child, and using apps to help you with working that out rather than trying to do it manually. So I think maybe I'll leave the last question to you. Do you want to take over and maybe, yeah.
Yes, thank you. Over to Bahati. Thank you.
Okay, just checking if everyone can hear me. Thank you, Agnes, for highlighting the important need to look at mental health issues. So with this case, it seems that the elevated viral load coincided with the mother's illness and death in 2019. And so the loss of a significant caregiver seems to have played a role with her adherence. And looking at her grief, has she had any grief work done? She will probably need to be recommended for individual therapy or a group setting if they could work through her grief. It would also be important to try and look at what does she know about her mother's illness. Sometimes children internalize issues that are happening in the home. Is she fearful of her own survival, seeing that she's been sick with TB, the weight loss, trying to gather information from her, what she knows about the illness and what she thinks about her own survival. So I would recommend that she would have a mental health screen, routine mental health screening to assess that. I'm not also sure if she's lived with this grandmother for a while. So to just check the adjustment. Was she living with her mom, and then when her mom passed, she then lived with her grandmother? What's the relationship like with her grandmother? What's the relationship like with these other 4 children that are in the home. How can we cement that? How can we support that so that during her grief and during the adherence counseling, she has an effective support system? I think it's also, I didn't get any information about the father. I think it's also important to look at, is the father involved in her care? Often when children are becoming adolescents, the issue around where is my father? Who is my father? Will he take care of me? I think that also needs to be addressed from a psychosocial aspect. So in terms of suggestions for improving adherence, I think disclosure is key. But whilst you haven't disclosed to her, trying to build a therapeutic alliance with her nurse or her doctor or whoever is going to be seeing her to establish trust and rapport that she feels safe enough to work through adherence with her caregiver, as well as a comprehensive assessment. So looking at the family's needs as a whole and not just the viral load or the medication. Is there any way that we can support the grandmother? She's 72, she's aging, she has poor vision. Is there anyone that can come and assist her in the home? Can she also get any medical care that will help her support her grandchild better? Again, trying to identify the social factors that are going on, the mental health aspects, routine screening for her, identify if there's depression, if there's trauma from seeing her mom being ill and dying and dealing with those issues. Also from experience, we find closer monitoring of a patient who's struggling to take their medication, if that is something feasible. And also now looking at telemedicine, if it's not feasible for her to come to the clinic quite often, a call to check if she's taken her medication. A pill box could also help. So trying to use telemedicine as a way of closer monitoring. Are there any community support services that she can be referred to that are closer to her, like a peer supporter, someone who is able to assist the grandmother? I think whilst disclosure hasn't been done, to also try and build her confidence, so behavioral modification techniques such as positive reinforcement, highlighting her strengths, looking at her efforts, even though the viral load may not have reduced to undetectable as yet. But if she is getting regular viral loads and they are coming down with significant logs, highlighting that to her and applauding her for that, to just try and build confidence that she's able to do this. And I think also what's important when an adherence strategy has been implemented, to try and do a home visit or a community visit to check how that plan is working out. Is this working for the family? Do you need to adjust and see what would work better? And in terms of the disclosure, from experience, I find that working with children who have been disclosed too late, there are more issues, the unresolved anger. Why was I just being told that I'm coming to the clinic without anyone informing me? So those questions do come up, especially with disclosure that is delayed. So checking whether cognitively and emotionally she's able to start a partial disclosure experience and then a full disclosure experience. And what is key is that once she's been disclosed to, not to treat it as a once-off event, but to try and provide support for the family as an ongoing, like a post-disclosure experience, where if there's a support group or a holiday club that she can join, meeting other young people who are living with HIV, continued close monitoring. So just making sure there's enough support around her, even after the disclosure, that it's not just a once-off event. Thank you, Agnes.
Thank you. Thank you so much, Dr. Akili and Bahati. So, I think what we're taking here is switch as early as possible. Don't wait. Otherwise, there's a risk of mutations, there's a risk of co-infections, and things to consider when switching. Weight, and not many people struggle with weight in our settings. Weight, but also chemistry in terms of, what are the other blood results of the child showing you. And I will try and share, I think I'm aware of the tool that Dr. actually mentioned. So we'll share that tool in the resources where you can enter all the variables for your client, and then it will come up with a calculation for you. So we'll make sure that we share that. I'll also share Anushka's tool that she's shared on this platform. You'll be able to find that in our resources. And then Bahati, wow, I mean, I'm blown about the number of things that we wouldn't have thought about. I think, you know, the way you've highlighted how we need to look at the child holistically in terms of other factors in the child's life that could be impacting adherence that we don't always sometimes think about. So thank you for unpacking all of that and getting us to think about the multifactorial things that might be impacting on the child's adherence, especially given that this is a teenager. So there were quite a lot of lessons coming out of that. So thank you. Now I'm going to move on to our next speaker, and our next speaker is Rhoda Kapatuka. Rhoda is from a health facility in Lilongwe Area 25 Health Center in Malawi. So I will hand over to Rhoda to present her next case. Thank you.
Hello everyone, my name is Rhoda Kapatuka from Area 25 Health Center, Lilongwe, Malawi. I'm here to present my case. Yeah, so this case involves a housewife, 23 years old. She delivered her twins on 3rd October 2021 at the health center. Take note of the date. There was a mistake on that. The date was supposed to be on 3rd October 2021, not to the 1st. It was just a typo error. So antenatally and after delivery, her HIV status was negative. Her twins too attend under 5 clinics for immunization and weight monitoring regularly, and they are all on complementary feeding to breastfeeding. The babies are healthy. HIV status of the father is unknown. On medical history, in August this year, the mother had access to HIV test kits, and her results was positive. On 8th August 2022, she came for confirmatory HIV testing, which came out positive. That was at the health facility now. So as soon as the results came out positive, she was initiated on ART and has been adherent to that. Initial viral to be taken in March 2023, that is after 6 months of ART. On same day, she had twins, 10 months old by then, had HIV testing, that's DNA PCR. The children were less than a year and were started on cotrimoxazole prophylaxis as exposed babies. One exposed baby, that's DNA PCR came out positive, and she was followed up and had confirmatory DNA PCR before initiating ART on 22nd of August 2022. However, at 12 months of age, that was now 13th October 2022, the babies had a test for HIV that was rapid, and was noted that one sample was reactive. Upon inquiry, it was discovered that the positive child was already on ART. That was the one that was having DNA PCR positive. Furthermore, it was then noted that the DNA PCR confirmatory came out negative. It was then decided to do another DNA PCR testing while continuing ART. The new DNA PCR result then came out negative, and the baby has been adherent to ART. Yeah, so this is just like a summary for the laboratory test that was done to the babies. So you can see that after the mother was tested positive, that's when on 8th August 2022, the babies were taken DNA PCR and were initiated on cotrimoxazole for prophylaxis since they were exposed. And then on 22nd August, the exposed babies, after that was the result. And then, and the baby that was with DNA PCR positive was initiated with that is ABC3DC plus DDG. This pyridoxine and CPT, we go it 15 ppm in Malawi. I don't know if the other countries. And then on 30th October 2022, that was when the babies were 1 year. As I was saying, the rapid test was taken again to all of them. And the other one was positive, the same one who was on a already. And the one with DNA PCR negative babies, the rapid test came negative. Now we took another sample, DNA PCR, like a new DNA PCR was collected. I'm just summarizing. While continuing with ART. And the one who had the rapid test negative was continuing with CPT. And now on 19th October 2022, the sample that was drawn on 13th October 2022 came out negative. That was the sample for the child who is already on ART. And we are still continuing with ART. Now, the key challenge is how to manage ART breastfeeding babies with rapid HIV test positive result 2 months after we've made a DNA PCR negative. Now, the questions for the expert panel. Number one, what was done wrong here? Number two, what would you do in this case? Number three, what do we do to the rapid positive twin? Number four, what do we do to the rapid negative twin? Thank you.
Thank you, Rhoda. Very, very complex case indeed. And I think I would like to challenge your first question around what was done wrong. There was a lot going on there. And I think whatever you did, I'm not sure they'll say it's wrong. It's just about knowing, how to best manage the case. So very complex. And I am going to hand this over to Dr. Sungadi to respond to your questions for us. Over to you, Nandita.
Hi, good morning and good afternoon, everyone. And Rhoda, thank you for that really interesting case. And just to echo what Agnes has said, I think there were some things that could have been done differently, but there was a lot that went right in this case, starting with the mother who tested negative during ANC and then negative again at labor, but actually had access to a self-test and was and still, continued to think about her risk and was able to do the self-test to find her, to discover her status, even though delivery had passed. And so usually we think, well, as long as the mother is negative at delivery, we shouldn't have to worry. I think that's the way we've been thinking about this, but we know more and more that women are continuing to become and acquire the HIV infection even during breastfeeding, and that actually increases the risk that they may transmit onwards to their infant. And we're actually seeing a higher proportion of infants that are now being acquiring HIV during the postnatal period. So the first thing I have to say is it's actually really lucky that despite having 2 negative tests during pregnancy, that this mother was still able to access an HIV self-test and encouraged to self-test at home and then return to the clinic for confirmatory results and management of both her own health and the health of the infants, of her 2 infants. Now, in terms of the testing for the infants. Now, these are they're twins, and sometimes we see discordant results in twins. One may become infected, one may not. And so that can be a scenario that presents. In this case, the DNA PCRs were sent appropriately. And secondly, both infants were started on cotrimoxazole. So again, the minute we discover that these are breastfeeding infants, that their mother acquired HIV during breastfeeding, likely, that we know that they are exposed and we want to treat them as exposed infants. So to start them on cotrimoxazole was definitely the right thing to do. In terms of the results, now when the first PCR results came back, what also was done correctly was a second confirmatory test was sent immediately before starting the child on ART. So that also is a best practice that very often gets, for some reason, gets left out. So there are times where children or infants are started based on the result of one DNA PCR, but we really do know that as we see fewer and fewer HIV infections in children, we actually know that though the sensitivity and specificity of these tests are actually quite high, when we're starting to see fewer and fewer infections, the positive predictive value starts to decrease a little bit. So we actually know that it's likely, or it's possible, that false positives may occur. Now, in this case, one of the errors, or one of the oversights here, was that confirmatory test that had been sent was not followed up on in a timely way. So we would not have delayed ART initiation on this infant after the one test, but we definitely would have wanted to check the confirmatory results once they came back. And that might have allowed for sort of a earlier intervention in figuring out this case. Now, that said, when these the infants returned to the clinic and an antibody was sent, I think it was mentioned in the case, and Rhoda, if there's any clarification here, that if I've mistaken this, you had presented it as one infant had a positive antibody, and I'm assuming the second did not. And there are a couple reasons in thinking about this. Number one, we're not being specific about which child the sample was sent on. And I will say, with twins, or when there's a number of infants that are around the same age, we have to be very careful about labeling. I think more and more, as we see fewer new positives in infants, that the actual we also have to think about the likelihood of error. So whether that is error that's introduced by us, or error because the tests are not perfect, we have to start thinking about that likelihood as well. In this case, the positive antibody that came up may have been from this child who was initially diagnosed positive on the first PCR, but it also may be reflective of the maternal antibody that has persisted. I believe those the infants were about 12 months old, if I'm remembering correctly from the case. And we know that maternal antibody may persist up until 18 months of life. And so it's not clear from that antibody result whether that was maternal antibody that had been that remained in one of the infants, or if it was reflective of the infant who was initially diagnosed as positive, if that was based on the infant's infection. And so, in terms of what I'm going to sort of take these three questions together, but what would we do in this case, or what would I do in this case? I'm going to start with the rapid negative twin. And number one, I'm assuming that this twin also had a DNA PCR that was negative. We may want to repeat that test as well, just to make sure. But we also want to remember that this is still an exposed infant. So even though we have a negative test, we know that the mother is now positive, and though she's presumably started on treatment and doing well, she still has the risk of transmitting through breastfeeding to the negative twin. And in terms of the twin who had initially tested positive, so now this child has had one initial PCR that was positive, a second confirmatory test that was negative, but we looked at this later after the fact, and then a third negative PCR test. Now, this becomes a little bit complicated because this child has also been on treatment already with ALD, which again is a very potent regimen. And what we are finding now is that when infants are initiated early on in life, they may not actually present antibodies. So the antibody that, if that was the case, the antibody that we saw in the rapid test, it may have been the maternal antibody and not the infants. Now that's hard to tell from just the antibody results. And the other thing is that we, again, may not see a positive result on a repeated test. And that's really the importance of the confirmatory test. And I want to stress that it's becoming more and more important that when we have an initial positive PCR, that we double check just to make sure by sending a second confirmatory test, exactly for this reason, because once the child starts on treatment, especially now that we have these more potent regimens, that it's very often difficult to make out after the fact if that child is truly positive or not, because the ARVs really impact the way that the virus is able to replicate in the body. And so at this point, I think, you know, we don't want to run the risk of this child. There are two risks here. One is that this child, we may think, oh, now with a second negative test, the child is negative, let's stop the treatment and sort of assume that the child is okay. And that may not be the case. So that's one risk. But the other risk is, what if we were wrong with that first test? What if that first test was the error and the subsequent negative tests were actually reflective of the status? Then we have started this child on lifelong treatment without a confirmation that this child is really positive. So this is actually something that I think we do see occur, and it can be very challenging because you don't want to run the risk of continuing treatment in a child that is otherwise negative. But again, retesting kind of this picture sort of changes after this child has been on treatment for some time. So in this case, I think it's a challenging issue, and I think people may deal with this a little bit differently in their different settings. These are both infants that you would not want to lose track of. So first and foremost, you would want to make sure that they remain in your care and that you're continuing to follow up on both of them. For the child who was initiated on ART with the sort of the positive result on the first test, at some point, if the child is healthy, if the child is doing well, there may be a consideration for temporary holding the treatment and then rapidly testing the viral load and testing for antibody again, because we do want to confirm that this child is truly positive if we are to continue on lifelong treatment. Now, I don't know if any of the other experts on the panel have any additional thoughts around that. I think that's a very delicate issue because, again, we don't want to run the risk of stopping a child on ART and thinking and assuming that that child is negative without remembering that we're really not sure. So again, the follow-up and the close testing and really confirmation is important. But what I want to stress more than anything else is just that the availability of testing, we have to be kind of cognizant that there are errors that do occur, whether it's human error or whether it's the error from the test itself, that we really do need to confirm diagnoses because once we do start treatment, it can muddy the waters a little bit, and it's difficult to tell once potent treatment has been started. Afterwards, antibodies may not develop, and we may have trouble confirming with a DNA PCR as well later down the line.
Thank you, Nandita. There's quite a lot going on there. Dr. Archery, I don't know if you want to step in and if you have any comments on this case before I pass over to Bahati.
Yeah, maybe just to comment around, this issue of, interrupting treatment. And again, it's quite a difficult decision to make. And I think, the difficulty with it is really around the mixed messaging that you're giving to the parents, and you need to manage that, quite carefully and making sure that they're prepared for it. Typically, as we unfortunately go through this situation because, often there's, positive results, negative results, indeterminate results that you have to deal with, and you have to try and work through it. Usually I try not to do it in the first year of life and allow the child, to be growing well. And I'm quite confident that they, growing well before I will consider, interrupting treatment. From our experience, what we do find is that even when you're interrupting treatment, if the child is positive, often the viral load will start coming up within the first to second week. So by the second week, if you do a viral load at that stage or a DNA PCR, if the child is positive, obviously you need to repeat it if it's negative, but certainly if they're positive, it's very likely to come back, come up, and then you can confirm the diagnosis and restart treatment. But I think it's just around being comfortable that the child is clinically well and that you are in a safe space to stop treatment and hold treatment for a while. And again, I don't use the word stop. I say we're holding the treatment for a short period of time to rule out any rule out any issues in terms of the diagnosis, with the possibility that the likelihood that is, if the viral load comes up again, we'll restart the treatment at that stage. And again, I think being honest and open with the parents. Thanks.
Thank you so much, Mo. Bahati, can I hand over to you?
Sure. So as I was listening to this presentation, there were a lot of what ifs. And I sat there thinking, I wonder what questions the mom has if we are sitting all with these what ifs. What about the mixed messaging? And so even though we want to talk about the twins, I think that the mother's mental health is also key here, so that she's able to also support her twins. So I would highly recommend looking at how the mother is processing her own status. She's recently diagnosed. She's also a mom. She has twins. That's quite a lot in terms of the caring that she has to do. And then one of her twins, there's this question about their status as well. So looking at the mom, how she's processing, screening her for depression, postnatal depression as well. Looking at trauma, I think it's key to look at the trauma, because she might think, have I infected my child? There's a lot of shame and guilt that can come with that. And even with breastfeeding could be a trigger. If we're saying that the children could have contracted while she was breastfeeding. So trying to explore with her where she is at with that. I think also looking at how involved is the father. I think his status was said to be unknown, and looking at the marital relationship, what will that look like when the father is aware of the status of his wife and children. But I think whilst we consider what's happening with the twins, I think for the twins to be kept under a good safety net, we also need to look at the mother's mental health. Thanks, Agnes.
Thank you, Bahati, and thank you, Nandita and Mo. Yeah, I mean, I was trying to follow the what ifs that Bahati mentioned, and it's really, really complex. And I think another lesson to add there for me is, as health providers, how do we present this information where there's so much uncertainty to mothers? And then, as Bahati said, how do we then support them if we're not sure ourselves? So to just really think about, once you've seen that client, they walk out, think about what's happening beyond that in terms of processing all this complex information. But I think what I also took away from this is the need for continued follow-up, even if mother and baby were HIV negative at birth, and also that well done to the team for starting on cotrimoxazole early. So lots of things that you did really well, but there were also lots of other things to think about and to consider errors, whether it's the wrong baby tested, whether it's maternal antibodies, so lots to process, I think, in this case. But thank you to our panelists. I will come back in case our presenters have questions to back to the panelists, but also others in the audience. But I just want to make sure I move to Constantia before we run out of time. And I'm really hoping that we'll have more time to unpack each of the three cases. Okay, so now I'm going to hand over to our final speaker, and that is Constantia. She's from Masinga Health Facility in Mozambique. And if I can just remind you to go onto the translation icon at the bottom and tune into the English channel, because Constantia is going to be presenting in Portuguese. So over to you, Constantia, and yeah.
Boa tarde a todos. Meu nome é Constância José, Sou técnica de medicina e ponto focal distrital do Programa Nacional de Controle de ITS-HIV. Próximo slide. Trabalho no Hospital Distrital de Massinga. Bom, hoje vamos apresentar uma história familiar de um caso clínico que apareceu recentemente nas nossas consultas. Trata-se de uma criança de 23 meses, do sexo feminino, que foi diagnosticada de HIV em junho de 2022, com 19 meses. A mãe deu parto em casa e amamentou até os 6 meses de idade, sem antecedentes de transfusão de sangue. Sua mãe recebeu cuidados pré-natais e foi testada para HIV com resultado negativo. Foi testada várias vezes para HIV. A última vez, o dia do diagnóstico da criança, até a última vez, o dia do diagnóstico da criança. O pai da criança mora em outro distrito, conhece o seu estado da criança, mas ele nunca fez teste de HIV. Ele mora no campo, sem acesso a serviços de saúde. Ele irá fazer teste de HIV nas férias de Natal, quando voltar para casa. A tia da criança mora na mesma casa e é HIV positivo, em tratamento desde maio de 2027, com a carga viral indetetável documentada desde 2019. A mãe do bebê refere partilha de objetos pérfuros constantes com a tia, como corta-unhas, e às vezes, quando a criança chora, a tia coloca o bebê no peito para acalmar. Não temos informação se o peito da tia tinha alguma laceração ou escoriação. E esta prática de colocar o bebê no peito para acalmar é comum nas áreas rurais. Próximo slide. Caso clínico. Em maio de 2022, nossa paciente de 18 meses apresenta uma história de diarreia com sangue, às vezes com fraco apetite e perda de peso. No mesmo exame físico, o peso era de 6,2 kg e o comprimento de 70 centímetros. Os sinais vitais eram normais, era pequena para a idade, sem icterícia e os pulmões claros na auscultação. Seu exame cardíaco era normal e apresentava abdômen normal, mole, com sons normais. Não apresentava edema. A mãe foi testada para HIV com resultado negativo. A criança foi diagnosticada de malnutrição severa e diarreia infecciosa. Recebeu antibiótico, suplementos de zinco e apoio nutricional com Plampinat. Após 2 semanas, a criança não apresenta melhoria e ainda a perder peso, pelo que a enfermeira faz teste de HIV com resultado positivo e refere para consultas tarde. Próximo slide. Temos aqui um resumo da história clínica, que em junho, após o diagnóstico, a criança inicia tratamento antirretroviral com ABC, 3TC e DTG, e continua com a reabilitação nutricional. Nas consultas seguintes, em julho e agosto, a criança apresenta uma ligeira melhoria de peso, passando de desnutrição severa a moderada. Slide seguinte. Próximo slide. No mês de setembro, a criança já apresenta um estado nutricional normal. E a última consulta em outubro, a criança estava assintomática. E a carga viral está marcada para o mês de dezembro, após 6 meses do início TARV. Próximo slide. História psicossocial. A mãe foi referida a cada consulta para apoio psicossocial para uma boa educação em relação à natureza do caso. Ela aceita a condição da criança e percebe bem como administrar os comprimidos à criança. A criança aparece à consulta nos dias marcados de forma regular, recebe visitas domiciliares. Próximo slide. Próximo slide. O que aprendemos deste caso é que o contexto como o nosso, com alta prevalência de HIV, precisamos pensar em HIV em casos com alta suspeita clínica, inclusive quando a mãe seja negativa. O aconselhamento em pessoas vivendo com HIV é uma parte importante dos cuidados, mas nestes casos é extremamente importante, dada a natureza do caso. Próximo slide. Próximo slide. Está. Bom, tenho duas perguntas para os expertos. A primeira pergunta é: não temos certeza qual é a fonte de HIV neste caso. É comum esse tipo de transmissão em bebês ou crianças? Tem casos ou estudos publicados sobre este tema? E quando e como a criança apanhou HIV? A pergunta 2. A criança está a melhorar após o início do tratamento. Sua situação nutricional também melhorou. Mas após 4 meses, achamos que o ganho de peso seria mais significativo, tendo em conta que está tendo consultas normais e reforço de adesão também com segmento regular. É normal ou tem alguma outra pesquisa que devemos fazer? Muito obrigada.
Thank you. Thank you, Constantia. I will swiftly hand this over to Mo to respond to Constantia's questions. Thank you.
Yeah, thanks. Again, I think really complex cases and really difficult situations to deal with. Again, something that we have to we quite often have to deal with, where you've got some sort of discordance between the HIV status of the mother and the infant. So there's several different possibilities and routes that you can in terms of the HIV transmission apart from vertical transmission. Certainly, as you highlighted, I think one of the commonest means that we see in our setting is especially in children who are weaning. There's a cultural practice of mastication of food where family members will masticate or chew the food and then feed the child that food, and especially if there's an HIV positive family member who has sores in the mouth, that can be a source of transmission. Again, additional family members or other individuals who are breastfeeding, who are HIV positive, may again be a source of transmission. HIV, transfusions, and if the child has admitted to hospital, required a transfusion or any other procedure, or whether it was a injection or unsafe use of injections that may result in transmission. And there's been quite a large outbreak of HIV in Pakistan that's been related to improper use of or reuse of needles that were administered at the clinics, and that was a source of transmission in that community. And then the last and the most difficult one is really around paternity and whether there was a switch of the baby at delivery, and this child is really not the biological child of the family. So I think in approaching that the situation, I think you have to separate out the two issues. And certainly, I think what I normally do when I speak to families who are dealing with the situation is firstly, deal with the current reality is, the current reality is that the child is HIV positive, he's got severe acute malnutrition and is really quite sick. And that, the treatment modalities we know, and we need to start that, and getting them to reach an acceptance in terms of, the HIV status of the child, and also, how do we improve the overall health of this child. And try to get the child to a better state. And I think, that should be the priority at the beginning. And then, that we'll deal with the considerations in terms of, the transmission, the source of the transmission at some stage. The one thing, when we discuss, when I, often, discuss with parents about this, because we often get, kids or families that are referred to us with this problem, is I'll start off the conversation by saying, in majority of the cases, we are unable to determine the exact source of the transmission. And that, we can look at it, but, it's very unlikely that we'll, know for the 100% certainty of, what the reason is. The one thing about the paternity issues is, I'll often not mention it unless the parent, brings it up as an issue that they are concerned about, because that's often quite a painful and a difficult issues to family to deal with. So unless the family is asking you to do it, because in South Africa we can do paternity testing, we often, I wouldn't even bring it up otherwise. And they're really going quite systematically to the history to look for, possible iatrogenic, risk of transmission, either through blood transfusions or injections. And then also in this case, feeding risks that may occur. Again, I think, the one of the difficulty things is, if the aunt is said to be biologically suppressed, the risk of transmission should be low. But there has been documented cases of HIV transmission through breastfeeding, even in patients with with a viral load of less than 50 copies per ml. Very, very rare, but it can happen. But again, around the duration of breastfeeding, and if she's had any ulceration at the breast or mastitis, that may increase the risk of transmission. So I think it's around having that discussion with the family, making them aware that that there's several different possibilities, but it's very unlikely that we'll be able to give them 100% confirmatory reason as to how this child got transmitted, and then dealing with the transmission risk. I think there was a question in the chat about the father and testing the father. So I think that's extremely important. And then, if the father is positive, to offer PrEP to the mother to ensure that she remains positive. There has been very, very rare occurrences of paternal transmission of HIV, because HIV can be integrated into the spermatozoa, so that the mother can be HIV negative, and then there's integrated virus within the sperm that can be transmitted to the fetus. Again, extremely rare possibility as well. So again, I think we're dealing with very rarities as we go along. In addition to that, I think the other question was around breastfeeding. If the mother is HIV negative, then she can continue breastfeeding. I think there's no contraindication for continuing breastfeeding in this case, and there's no risk really of cross infection in terms of the baby to the mother from there. The second question, and I'll leave the psychosocial issues that's quite extensive in this to the experts. But I think in terms of our experiences with ART, with severe acute malnutrition, what we have do find is that the weight gain tends to be far lower or slower in HIV positive children, who with severe malnutrition, as opposed to the children who are HIV negative. So you do see quite a slower trajectory in terms of their weight gain. So it's around being a bit patient and looking for those changes in the weight. The other thing that just to mention is that the first 3 months in children with malnourished and HIV infected. So when we did a study at our setting, and that first 3 months is a period where it's probably the highest risk of mortality around it. So it's really around making sure that they're taking their treatment, that the nutritional recovery is going properly, and that you giving the appropriate prophylaxis and the nutritional support to ensure and micronutrient support to aid the growth of the child. So being very cautious in that first 3 to 6 months to ensure that the child gets over that hump, and then once they hit that 6 months and their weight improves, they almost like any other child on ART. But I think it's just around in that first 3 to 6 months to be extremely cautious, and they may require either home visits or more frequent visits to the clinic to just monitor them and making sure that everything is going well. Yeah.
Excellent. Thank you so much, Mo. I will hand over to Bahati. And Bahati, I think when you respond, again, there's lots of uncertainties about what might not have happened, to speak to how we communicate these uncertainties with health providers, because for me, that communication with caregivers is also really, really vital. So I'm hoping that you'll address that when you respond to this question. So over to you, Bahati.
Okay, thank you, Agnes. So like you said, this case is complex, and I like what Dr. Mo highlighted. A family conference, I think, is key. So not just focusing on the mother, but if the father is able to attend, it would be key that he also gets the messaging and it's not relayed by his wife. As a lot of questions may come up that she may not be able to answer. She may be anxious about telling him alone. So finding out from the family what would work for them. I think it's also important to look at the cultural and spiritual aspects of patients. It's not really common in medical settings, but I think when you want to look at a person, you need to look at them as a whole being. So to try and understand them beyond just the art, beyond transmission, what are their understandings about the transmission? Whilst we have questions about it, do they have alternative beliefs? Some patients believe it could be spiritual, the child was bewitched. There's a lot of secrecy that happens with pregnancies in African settings. So to explore with your patients what they believe about the transmission. I think it's also important to highlight in the family conference, like what Dr. Mo was saying, that we are unsure and we cannot give you 100% a confirmatory that it was this. I think being open with your patients and not wanting to look like we have all the answers and yet we do not. And so being honest with our patients about how far we can answer certain questions and exploring together with them what they think is going on.
Sorry, Bahati. We are hearing, I think, Portuguese translation in the main platform. Please go ahead, Bahati. Thank you.
Okay, thank you, Agnes. And from our clinical experience here, we found that these unanswered questions with regards to transmission often then pop up in adolescence. And the adolescent will ask, how did I get the HIV? How come my parents are negative if it turns out that both parents are negative? And that could precipitate a lot of unresolved anger and depression, which then comes out the thing that you see are behavioral difficulties, like not wanting to come to the clinic, not wanting to take art, what parents think as disobedience in the home. But those seem to just come out of the stem of trying to understand what happened to me. So it's an important thing to look out for. I know that this is still a young child, but it's important to just have a finger on it that behavioral difficulties could come up because of this unanswered question regarding transmission. And helping the family, sometimes when a family is prepared for these things, when it does happen, it's not an ultimate shock, or the child then isn't treated in a harsh manner that then further alienates them from the family. So I think we need to look beyond the art and the transmission, but to look at how can we holistically help the patients. Thank you, Agnes.
Thank you, Bahati Mo, and thank you again, some really, really great lessons coming out of this case, looking at, and I think the one thing that I've had Dr. Mo mention twice is looking at the clinical wellness of the baby, the first thing before you do everything else that you have to do. So I think that's really important. And just to bear in mind, there could be many, many ways of transmission in cases where we're uncertain about, like in this case. So I'm glad that Bahati, you've given us ways in which we can try to unpack this and help parents understand. But the one thing that you've also mentioned a couple of times is the family involvement, especially when it comes to fathers, whether it's to do with cases like this, but just in general, I think father involvement in the care of whether it's children living with HIV or not living with HIV is really, really important. So it'd be, we must bear that again as a subtext learning from this platform. So now what I'd like to do, I can see there are a few questions in the Q&A box. I'm gonna ask our panelists to have a look and see if what you would like to respond to, or what you can respond to, because there are lots of questions. And I can also see some comments, which are great contributions to the learnings that we've had in this platform. And then the third thing, Luan has posted one of the dosing tools that could be used for calculating dosage for infants. So have a look in the Q&A box, you'll find that there. But what I'd like to do is to turn back to our presenters to ask you if you have any follow-up questions, because I think you just listened and taken in, but you may have more questions. So we have about 15 minutes left. I'm going to start with our first presenter, Anushka. Do you have any follow-up questions for the panelists?
Hi, Agnes. No, but just want to thank them for the very useful information they provided. Thank you.
Okay. Excellent. I'm glad we're covered. And then over to Rhoda, and Christopher, I know you're with Rhoda as well. Are there any follow-up questions for the panelists from what you've heard today? Rhoda and Christopher, are you able to unmute and respond?
Yeah. Yes, I'm able to respond. There's no question.
No, covered. Oh, I'm so glad. Our expert panelists are doing a fantastic job. And then my last question is to Constantia. Do you have any questions?
Bom, eu não tenho, as perguntas que eu queria fazer são as que eu já fiz e agradeço pela oportunidade. Muito obrigada.
Fantastic. I'm glad we're all covered. So I would like to to our panelists, are there any questions in the, I'm just going through the chat box. Some of them are mainly comments. There's a question from peer educator in Uganda. Never had suppressed viral load. How can I support? So there's a question from a peer Gloria from Uganda. I have a child I support and he has never had suppressed viral load. How can I support this child to do as he can have, so that they can have a suppressed viral load? I think Bahati is typing an answer to that. Bahati, would you like to speak to that?
Okay, thank you, Agnes. So I've just stopped typing. What I wanted to highlight is to look at the underlying causes of the adherence. So whilst a suppressed viral load is what we want, it's a target for HIV management, we need to look at what is the underlying issue rather than just focusing on the suppressed viral load and giving information about take your pills, this is what's going to help you with your viral load. Explore together with the child what are the difficulties for him taking his medicine, his or her medicine. Children often relate to concrete activities. So if you can include art, perhaps have an environment where they feel safe enough to talk to you, writing, exercising. Sometimes talking directly is very threatening for children. So maybe asking them to write, even write a letter when they're at home. Often you will have questions about why am I taking this medication, and it can lead to the disclosure aspects that we highlighted before. But I think the key thing is to try and understand why the child is not taking their art, beyond just telling them that this is going to help you or to keep you healthy. So rather than just focusing on a treatment literacy, but trying to find out what exactly is happening and trying to work together with caregivers if they're available.
Excellent. Thank you, Bahati. And I think there's a question from DRC. I think that speaks, Bahati's response speaks to your question as well. There's a question from Maria as to whether, for Constantia, as to whether the aunt had been initiated on treatment and cancelled. My understanding is the aunt was on treatment and virally suppressed, but perhaps Constantia, you could speak to that for us. Was the auntie of the baby on treatment?
A tia foi diagnosticada em 2017 e iniciou o tratamento. E em 2019
Now,
estava com carga viral.
Yeah.
Não percebi. Em 2019 estava com carga viral indetetável. Em 2021, 22, idem.
Perfect. Thank you. Thank you for that.
So just to make a comment around that. So I think, again, one of the difficulties, again, in this family dynamic, especially if they're living in the same household and you add causation and you add guilt and, blame to the whole situation. I think, again, you do need to deal with it in a very sensitive manner. Certainly, I think, the intention of the aunt was certainly not to transmit HIV to the child. And I think we need to be extremely sensitive, as we bring up this topic and we try to deal with it and really think about the family as a whole dynamic. And I did put this in the chat. I think the one thing that I forgot to mention, and is obviously a very painful thing for us to even think about, is really around sexual abuse of young children, and that's does unfortunately is a reality, and even in very young children has occurred. So it's again one of those ticks that you do need to make sure that you've ruled out. In terms of one of the possibilities for transmission risk.
Thank you, Mo. And I mean that again, where the suspected sexual abuse comes with a whole lot of issues, and this is where people like Bahati can help us in terms of how do we even start to engage with that conversation with parents in a safe way that's not going to split families. And I would like to ask our panel if there are no more questions. I'm not seeing questions, it's more comments in the chat box. I'd like to ask our three panelists to just finish off by telling us from their perspective, what should healthcare providers walk away with from this platform, from this webinar? Maybe I could start with you, Mo, and then I'll go to Bahati, and then Nandita, if you could then give us some closing remarks as well.
Yeah, so maybe I think the one takeaway message from my side is, I think, just to understand, as a healthcare provider, we often think that we know everything. So I think, just to be, we often humbled by, the situations that we are faced with and the patient and the situations our patients are faced with. What I do find in my interaction with families is to be as honest and open as possible, acknowledging what we know from in terms of certainty and what the uncertainty is, and that we're working together as a team to try and work through that, to achieve what we both want, both as a parent or a caregiver and as a healthcare worker, is to ensure that the child gets is well and healthy and grows up to be a healthy adult. So I think it's really around dealing with that uncertainty and being honest with the families and taking them along in the journey with us. Thanks.
Thank you, Mo. Bahati, if I can pass over to you.
Sure, thanks. I think it's important for us to look beyond the biomedical and look at the psychosocial and the mental health aspects that our patients could be facing. And not just to look at our index patient, but to look at who surrounds them, how can we support those people, so we're creating a safety net. I think it could be also very overwhelming if you try and deal with it alone as the healthcare worker. So I think working in a multidisciplinary team, referring where appropriate, linking patients to care, ceases to make the issue sort of your own heavy issue to then work with and to deal with. So I think looking for wherever you can, partnering with community organizations, or if you have resources, and having a multidisciplinary team around you is quite key.
Excellent. Thank you, Bahati. And Nandita, your key takeaways, please.
Thanks so much, Agnes. And these were 3 really great cases. And I want to thank the presenters for sharing them with us. I think they really bring out some of the key issues we're still facing in pediatric HIV. And I really appreciate what Bahati is saying about paying attention to more than just the biomedical issues. The tools that we have at hand to treat pediatric HIV, we've come a long way, and we have the testing capability. So we have access to early infant diagnosis. We have access to viral load increasingly. But one of the things that I really want to also stress here is tests are only so helpful if we act on the results, if we have the results and we act on them. And I think that's something that came out very clearly in the second case. But one last point I want to make, and this is applicable to what Bahati is saying, as well as across all 3 of our cases, is that it really is on us as health providers to know our patients, to really understand what context they're coming from. And there's no lab test or a protocol that can take that place. And so we really need to understand, for example, in our first case, where this young girl is coming from, what developmental level she's in. From the second case, we were talking about when do we hold treatment when the child is well, when the child is growing and healthy, to determine the status. And even in this last case, understanding that we have to go into the, number one, testing a child when you're suspicious for HIV, and then really looking at the whole family. And again, I think as healthcare workers, some of these are diseases, and as Dr. Mo mentioned, there's still uncertainty. But I really also think that it's important for us to look at our patients and to see them as individuals and not just the results on from the lab test. So I really appreciate the care that went into both taking to put these cases together and present them. But the questions that have been asked are excellent questions, because I think these are still issues we continue to work out together today. So I thank you to PATA as well for putting together the PATA Real series. I think it's a great way for us to learn from one another.
Thank you so much to our panelists. And I think Mo and Nandita have echoed before we started this webinar, how valuable having Bahati was going to be. And I think she's proven it. It's, I don't know how we've done this without even talking to mental health or psychosocial support. So thank you to my 3 panelists for an amazing webinar. I would also just really like to thank our health providers. It's not easy. I know we've been communicating with you, but did you do this? And it takes time to go and find the lab results to make sure the story makes sense. So I don't undervalue the amount of effort that's gone into preparing the cases. So really a huge thank you to you all. And as I said earlier, to Christopher Yamkani, who's been supporting us with supporting the health providers, as he understands more better than us sitting in an office. Christopher is actually in the field and understands the challenges of trying to get such information. So it's really amazing to have him on board as well. So thank you, everyone. And I would like to wish you all a good evening, and hopefully see you all tomorrow in the Prime session.